Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in. So I am here with Dara Kass, Dr. Dara Kass. I want to say welcome. I am so thrilled to be sitting with you here at the Drake. I know people cannot see us right now, but we are here for the Power In of Women in Medicine Summit that Dr. Shikha Jain has organized, founded, done all of that stuff. First of all, I want to say thank you for sharing your time. I heard you speak yesterday, absolutely inspiring, and I'm looking forward to exploring a little bit more with you in this conversation today. So before we get started, can you tell us a little bit about yourself?
Oh, well, okay. I'm 48 years old, so it could take a while.
But Capricorn?
Yeah, Virgo. So I would say that the most relevant thing for me, so I'm an emergency medicine physician.
Okay.
I graduated from residency in 2007 to give you a sense of how long I've been doing this. I spent the beginning of my career doing a lot of education work, residency development, medical school education, stuff like that. And then I pivoted in 2015, 2016 to found an organization called FemInEM, which we'll talk a lot about. And that was really in response to needing to create an organization that supported the careers for women in medicine from really a collective action perspective, right? So less talking, more doing, but really neutralizing a lot of the biases women face in advocating for themselves. So by having an organization that centered things like maternity leave or lactation or promotion or salary transparency, we destigmatized the idea that any individual woman physician needed to think about that or advocate for it, and we put it in kind of a neutral third-party entity. And then, which will, I think, come out as a theme, I am very good at, I'm going to say, falling on the sword for people, but I tend to, can we curse on this podcast? I don't know.
You can if you want. We can bleep it out.
Okay, well, I tend to give less you-know-whats than most people, and I tend to think about when the system is broken, fixing it is the only option. So knowing that I could start, lead, and kind of envision an organization that would help other women in our field stay employed, stay active was a no-brainer for me. And then after that, so there's a lot about FemInEM we'll talk about, but I wound up working in the federal government. In 2021, I became the regional director at the U.S. Department of Health and Human Services for New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands.
That's an interesting state mix.
Yes. I was saying yesterday a little bit that, it's where people emigrate to. So they put the Puerto Rican and the territories of Puerto Rico and the U.S. Virgin Islands in New York and New Jersey, because a lot of people who, when they come to the continental United States, that's where they live. But at least that's what I told myself. But the bottom line is that I really wanted to learn more about the federal government, because you can't fix it something you don't understand. And so by that time, I had realized how broken the system was, not just within healthcare delivery of the careers of women in medicine, but how people received it. And what does the federal government do? And I really wanted to understand more, much like a residency. I went into the federal government and had that job. When I came out, I did a lot of work on reproductive health care, because while I was in the administration, the Dobbs decision came down. And now, where I would say like the focus of my first phase of this work was on the careers of women in medicine. While that didn't get solved, we have this other kind of looming threat to the lives of women in medicine. And so I felt like I needed to have a better handle on how to connect the dots of what needed to be done on the ground for patients seeking care in emergency departments and the physicians who are giving that care, right? What does it look like to teach people legal and safe care in the state that they live in, because they don't even know the laws? And then also still do the work of the gender equity advocacy work that we had done before, helping women connect on things like professional development, well-being resources, and stuff like that. So that's a lot. I mean, that's probably 4 minutes or so of who I am and what I do. But that's kind of the primer of all the different hats that I kind of wear right now, and the work that we're doing going forward.
Yeah, that's just amazing. And so we always talk about that a lot of the guests we've had on this show didn't set out to be in the position you're in right now. It kind of, you just kind of fell into it based off of your passion. And would you say that has kind of led you where you are, that a door opens here, a door opens there, This
Yeah, I would say that I could not have imagined that this is what I would be doing when I was a resident, kind of 20 years ago. Mostly because it didn't exist. Like, I mean, so much has changed, right? Social media, the advocacy of the advent of all of the ways that we communicate and gather right now. Like, there were no women in medicine conferences until we started them. I also think that my life, I'm an emergency medicine physician. Ironically, that's the one thing that's been constant in my life is the desire to still work in an emergency room at some capacity. I don't think I did not do well for the 3 years that I was in the federal government. I could not work in the ER. It was actually prohibited as part of my job. And I volunteered, quote unquote, in the Manhattan VA. It has to do with whether or not you work in a Medicare or Medicaid receiving facility. And I lost a part of myself. I being in an emergency department, like
that's part of your
in
identity.
yeah, talking to people, introducing myself, solving those problems is so much a part of who I am that I just couldn't not do it. So I think that I'm still that person that I was 20 something years ago when I started this. But I also think that the other issues that we're facing, I mean, I think I took a lot for granted when I was a resident and I was
Oh, we're
imagining
young.
the kind of doctor I was. And I took the idea that we would have, reproductive autonomy and it would get better. And the fact that we've backslid so much in the past 20 years as far as our healthcare access. I mean, we've had crazy innovations and there are obviously remarkable things that have done, but we have we know, I know how much better we could be doing. And so I think that that awakening and that call to action is something that I can't ignore. And that was what frames out a lot of what I
So what is the biggest challenge you're facing right now?
do. um,
Or I should say opportunity, right?
well, I think, no, I think, look, um, things are really not good. So somebody asked me today, how am I doing? And I said, in my bubble, I'm doing great. Meaning if I would put up blinders about the entire world and say, in my home life is great. My children are great. My family, my husband, my marriage, we are secure and healthy. And thank God that's wonderful. My job is great insofar as I go to work in an emergency room where I enjoy taking care of the patients. I like the people that I work with. I am grateful for that job. The organization that I run is great. I work with women physicians across the country with a collective sense of purpose. We are as well funded as a nonprofit can be for the work that we do. Um, there is no limit to the amount of projects that we can take on, and we feel like inspired by the impact that we're making. So, in that way, I feel fantastic. And the minute that I look outside that bubble, it's overwhelming because I am solving one of the many problems in front of us in the US healthcare system. And so I think that the thing that I have to reconcile sometimes is there's a lot of media that I consume and information that I take in that I choose to not solve because I can't solve everything all the time, even if I'm aware of it. And that's a hard thing for me because I'm a problem solver
Right.
by nature. So knowing that there are problems out there that I will not try to solve or be part of the solution is actually a difficult thing for me to deal
And
with.
being very conscious of that decision that, okay, I recognize that, but I'm not taking it on right
Right.
now.
That
Can't do it.
if there's somebody else that I know is out there that might be a better fit for that or can take on that right now, I might
Sponsor them and say,
yeah,
hey, check with these three people.
I do a lot of connecting. I can't solve this problem, the other person can. Let me put it together. But for me to not be the primary, problem solver of an issue is still something that I wrestle with all the time because I feel like when I go after a problem, I do a pretty good job with it, and and there's just so many problems to solve.
Yeah. So being at this conference, I always come away, this is my third year here, just being absolutely awe-inspired by the incredible women here. Where do you draw your strength from? I know you do a lot of speaking, you're at a lot of different conferences, but what are your touchstones? Like what gives you like fuel to
What
keep going?
what fills my tank, right?
Yes, what
So,
fills the tank?
um, I the so I am driven by other people. So I'm an extrovert, clearly. So being with other people, being in community with other people, getting the best out of other people really drives me. So I don't do anything by myself. Like I like my little alone time to recharge, but I enjoy thinking out loud. Doing this work. with so many other women is so good for me. Watching them thrive, getting projects funded that they can then go and travel, the feedback we get from the work that maybe I helped imagine or accelerate, but I am not the person on the ground doing the work. That is what drives me. Building an army,
Mhm.
if you will, and funding that army, which I think is one of the things we should talk about, which is how did we get funded? And more
Yeah.
importantly, you know, women. So my husband and I talk a lot about the work that we do, and he works in finance. And his North Star had historically been making money, right? Insofar as that was the value thing, the kind of value metric that he was trained meant that you were worth something to society. And if not, it was going to give you freedom and flexibility to do other things that you wanted to do. I've never, I haven't been that like transactional about my time, but I also haven't been that altruistic about my time. So I see so often, and I was having a conversation about, influencers today. Um, women, excuse me, women spend so much time giving away their time for things that make them feel good, valued, or like they're contributing to society. And it often isn't the thing that's paying their bills.
Yeah.
And when it comes down to like FemInEM and how we're doing it, if I can make this work pay somebody's bills, then that's kind of everything. Right? Because this is the work we're driven to do, right?
But we
Making
want to be
ER
paid for it.
right. We need to be paid for it,
Yeah.
right? So I have conversations a lot with the physicians that we work with. We're not all women per se, although right now that they don't have to be, is that I tell me what your project you want to do. Tell me the thing that you're trying to work on. Tell me the problem you're trying to solve. If it fits within our bucket, that's amazing. And then I'll tell you if I can get somebody to pay us for it. If I can't get somebody to pay us for it, you then have to decide, do you still want to do it for free? But before you start doing it, we're going to talk about whether or not it's going to pay you any money. And that honest conversation about whether or not you're going to give it away before you start doing it, women tend to
We
not
do.
have.
Yeah, I was gonna say we do that all the time. We're like, "Yeah, sure, I can help you with that. I'm happy to do that for free." So, where are you going for the funding?
So we're very fortunate insofar as um, I knew after doing work in the federal government and some other advocacy and consulting work that I had done, there was foundations out there that were interested in solving the problem about, reproductive health care access for women in a very tangible way. Could you show them that you can make a difference in the care delivered on the ground in ERs tomorrow? And because I know the field of emergency medicine is, I think, as well as I do, I know the people that work in emergency medicine, I know the kind of human that shows up to work in an ER. And they want to do the right thing, but sometimes they don't know what that is. And so if I could just connect the dots between what is legal and safe with the people that want to deliver that care, I could feel pretty good that by the next shift, they would try to do better, better than they had been empowered to do the day before. It's a huge lift to say we're going to travel the entire country and touch all of the doctors and, that
And all the
serve.
different state regulations.
And you're gonna have to know. I mean, so in the work we're doing right now at FemInEM, and I was explaining this a little yesterday at the conference, it's a 50-state strategy, which is overwhelming to most people. It's not to me, which is the truth. Because all these projects are just one step at a time.
Yeah.
And so we chose to start with Texas, which is kind of like the same. Like I grew up in New York, right? I'm a New Yorker. If you can do it here, you can do it anywhere. If you're looking at solving the reproductive health care crisis in America, Texas is a good place. Yes.
Texas is a good place to start.
Right. So if you can solve it, if you could attack a problem and do it in Texas, that is legal and is as evidence based as you can be with the current state laws, and you can map out the healthcare of Texas, which is so different than the uniform healthcare that we see in other states that have much smaller health systems and much fewer providers and much less diversity of community, right? Because there's these rural communities and there are these freestanding emergency departments and there are big health systems. If you could map it out and even try to make a meaningful impact in Texas, every other state short of California becomes gravy.
Mhm.
right? And so that was where we started. And when we were starting to see incredible successes, knowledge translation, physicians feeling empowered, the stories from people from across the spectrum politically, but all in the bucket of emergency medicine, excited, empowered, and grateful for the education, it immediately validates time. The women that are doing the two physicians that are
I was gonna
traveling.
say, you introduced them yesterday,
Yeah.
and they love getting to go to different places.
And it started because one of the physicians came to me after doing one lecture and said, "That was amazing. How could I do this everywhere?" And I said, "You want to do this everywhere? Let's figure out how to make that happen." But if I do, you're going to have to do it everywhere. And so it's very much imagine the program. I'm going to think about where we can get it funded. If we get it funded, we got to do what we said we're going to do.
Yeah.
Right? So the other part about, conferences like this, grant funded projects is you can imagine great things. But at the end of the day, if you say you're going to do something, you've got to do it, or else you're never going to get that funding back again. And so, what's been rewarding over the past 9 months of this iteration of FemInEM is that we're killing it when it comes to impact. We are showing that doctors across the country want this knowledge. They want it faster and now and yesterday. And so they're inviting us in to lecture. And again, it's surprising people because the people that wanted to solve this, I think, didn't think that that we as a community were either as uniform as we are or as interested in delivering good healthcare as we are. And so it's been nice to kind of like pull back the curtain a little bit for funders to say, if you fund us,
This is what you're gonna get.
this is what you're going to get. And it's going to be what you think it is, which is the community of emergency physicians, and then OBGYNs, and then our family medicine colleagues, and then our pediatrics, like everyone coming together to just deliver as best safe healthcare as we can in this current climate.
Mhm. Can you talk about some of the resources available? Because I think you had a number of things, different treatment algorithms, different decision trees based on.
Yeah. So from a reproductive health perspective, um, one of the things we've done at FemInEM is we partner with an organization called Access Bridge, which is a different nonprofit that worked on basically creating protocols around these areas of care, so that if you're in a state or in an area that's not necessarily well resourced or maybe even has confusing laws, there was a third party resource that was not you didn't do it by yourself. It's very
Right.
some of the bias that we faced originally with FemInEM. This third party resource would say, "This is how we treat an ectopic pregnancy. I'm not trying to give an abortion. I am trying to treat somebody who has an ectopic pregnancy. And look, this evidence based nonprofit says this is when I'm supposed to act. I need to do this because this is medicine, right?" And there really wasn't in a post-Dobbs era, there wasn't like content that was created to give cover to physicians, even if the medicine hadn't changed, the landscape people were practicing in did. So what we did at FemInEM was basically like the protocols are like a tool, and we created the toolbox and then larger toolkits, right? So we have on our website under resources, we have an entire page dedicated, let's say, to contraception initiation in the ED, which includes CME content that we've written and filmed that allows us to teach people about how to initiate contraception. It has links to websites like what was at the CDC around the criteria for different contraception methods. It has videos on like insertion of long-acting contraception so that you could understand, even if you're not going to do it right away, how to put in an IUD or how to put in a, Nexplanon in your arm. So it has a lot of like multi-layered resources, things like options counseling, websites that are interesting and important. And we have that for early pregnancy loss. We have that for ectopic pregnancy. We have that for medication abortion. So the other thing that we are unapologetic of is that in states where it is legal, it is worth it to think about medication abortion dispensing from emergency departments, which literally means that for patients that do not want to stay pregnant, where the care is allowed, emergency departments should serve as an access point for that care. That has nothing to do with the politics of medication abortion or abortion writ large. because emergency departments serve as the access point to care for everything else in America.
Mhm.
There is there are no other kind of time sensitive decisions that a human makes that are treated with a pill that you couldn't get in an ER. And so, as long as there are protocols in place and as long as the administration is supportive and as long as the legal requirements are made, we want to facilitate departments being able to add that into their kind of provision of service. And there are places like Stanford, there was a talk yesterday about that, that piloted that and showed how successful we can be in adding that service for patients. There are hospitals that are doing it via telehealth only. And so systems have virtual kind of urgent care access for medication abortion, which is similar to startups that are out there. And there are hybrid models. And most importantly, and I said this yesterday, if access to mifepristone, which is the abortion pill that people talk about politically, changes, being able to access it from the emergency department is going to become critically important. Because patients who have been evaluated in clinics, so not primarily in ERs, are going to have to come to the ED to get the pill because they're not going to be able to get it from a pharmacy. And the clinic that evaluated them is not going to be
Not
open.
gonna have, I mean.
And so you're going to have to be able to say, here's my prescription that I have for this pill that has to be dispensed in person from a provider, has to be witnessed, and you're going to see it whether we want to admit it or not. People coming to the ED with a prescription and saying, can you please give me this one pill that I've already been screened for, that I've already discussed the options with, that I'm already legally allowed to have. But the constraints around access have changed so much that I have to come to an emergency department to physically pick it up. And I'm trying to prepare people for that reality.
Mhm. And it's gonna come. So we have a lot of med students here at this conference, a lot of early stage career physicians. What advice would you give them if they want to get more involved?
So my son thinks he wants to be a doctor, right? And it's very funny. And I keep saying to him, okay, great, let's go slow. And it's funny because I don't do anything slow. Um, and the reason I say like that is that life is long, God willing, and there are a lot of problems to solve. And there will continue to be more. If I tried to envision this life when I was in if I had if I had a phone, like a cell phone in medical school, I mean, like, we just literally had, like, flip phones. If I had, like, text messaging and social media on my cell phone in medical school, I don't know that I would have graduated, okay? I have such bad ADD, like, I'm not disorganized, I'm just nonstop, that I would say to them so it brings me to the medical students here to say, yes, of course, you should be aware and active, and yes, advocacy is critically important, but you've gotta become a doctor first. Like, none of this matters if I am not on the ground seeing patients and knowing what the impact of this care is for people. And what I'm seeing now, and it's like everything else in America, right? It's like we like came at this, we're like the boomer generation, right? Like we were deeply educated and learned offline and knew medicine, and then social media exploded and we all kind of learned how to tweet, and then we maybe did a podcast, and now we're kind of at this bridge of like social media and, medicine, but we had that foundation of knowledge first. I really worry that medical students today, because there's so many problems to solve and because they're so consumed by feeling the weight of the world, are not able to focus on the medicine in front of them. And so what I would say to them basically is, don't solve all the problems today. If there's one you really care about, keep it on your radar, but pay attention to becoming a doctor first, because you're never going to you're never going to get that back.
Any parting words?
I still have hope. I mean, if I don't have hope, I don't know what to do. I think that it's a lot is overwhelming, especially I think the past couple weeks have been really, really hard. I think that we have really a lot of the information that we've seen lately around, gun violence in America, and the narrative around, vaccines and other healthcare policy that isn't even about reproductive health care, is crushing. And in my little bubble,
You have hope.
I have hope. And I, like, need to get that hope back in my heart, as I am in my bubble, that I need to go out into the world and take that energy to solve the problems in front of me. So as long as I can do that, I'm going to be okay.
Well, we are so lucky to have you here at the Power of Women in Medicine Summit. I am so lucky to be able to have gotten to sit down and talk with
This
you
is
some
great.
more, and I do hope we can stay in touch. And where should folks go if they want to learn a little bit more about you?
So for me personally, I would say that it's at Dara Kass on all platforms, although my platforms are not nearly as dynamic as they were during COVID and certainly not when Twitter was a thing. But I am out there. I would say that FemInEM is www.feminem.org, which I think has a lot of resources. And then I actually have a personal website, which is literally darakass.com, which right now is really a great way for people if they have questions for me, particularly, or they have things that they want, you know, certain speaking things, or I just did a debate about COVID that came through that website. So if there's anything that I can do individually separate from FemInEM, that's a great way to get in touch with me.
Awesome. So thank you so much.
Thank you.
Be in touch. Take
Bye.
care.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.